And Elijah, thank you very much for the invitation to speak here. And I don't know if anyone has noticed, but there are 3 speakers from our university speaking here. And that is probably because we do a lot of research, but this picture shows you why we do a lot of research. So this is our academic university center. And as you can see, it's situated in a completely boring area of Amsterdam. And the only thing we can do is stay inside and just work. Because I've seen these lovely pictures of hospitals and universities from the other speakers. We don't have that. But to Amsterdam's credits, I put this picture in as well, so that you can see how lovely our city actually is. Okay, now back to the topic. I want to talk about new approaches to device therapy for sudden cardiac death. And I always like to dramatize things a little bit. We've seen the numbers already, but now visualized. The number of sudden cardiac deaths in the UK equal 2 Boeing 747s per week coming down, killing people because of this affliction. And most of it's caused by VF, ventricular fibrillation. And these devices, and those devices, that's the ones I'm going to talk about, are currently the best protections against sudden cardiac death. So these are state-of-the-art technology, and they bring us a lot of good. They save lives, and there are a lot of studies that have shown that. So after the secondary prevention studies, where the first indication started, and we started to implant on a large scale ICDs, then the primary prevention studies arose, and they caused us to even implant more ICDs. But one of the first lessons I learned in medical school was this, and you have learned the same. First, do no harm. And with the use of these devices, this is actually what we're doing. Because when we use these devices, we inflict damage, like this pneumothorax, happens in 1 to 2% of the patients. We create these large hematomas, especially in patients who use anticoagulant drugs. And sometimes when you think the lead is in the apex, a few days later it's not in the apex anymore, but it's perforated through the myocardium in the pericardial space, and you get a dangerous tamponade, and people can die from this. And that's not the only issue. The largest issue actually is the lead. Leads tend to break with a rate of 1 to 2% each year, and then we also know that there are certain leads, like the Riada lead or the Sprint Fidelis lead, who have even more issues. So, more trouble, more harm. And chronically, if you have the device implanted longer, some of the devices tend to pop up under the skin, or even the lead pops up under the skin. And it gets really nasty when things like this happen. Infections, and here you see me evacuating a pocket full of pus. Luckily you just had lunch. And this is really serious, because the mortality, especially if it's a Staph aureus infection or a device infection, is 10%. So this is serious business. And if that happens, we need to do these drastic things like laser sheet extractions, which we do in our center. This is one of our extracted leads. You see from the material that it's not a very subtle procedure. And sometimes the vegetations on the lead are that large that we need to crack the chest to get them out. So, ICDs, state-of-the-art devices, but there's something wrong with them. So I summarized the complications a bit from the SCUTHAF trial: 5% acute complications, 9% chronic complications. So about 14% surgical complications associated with these devices. And then we're not even counting inappropriate shocks of these devices. So there's something wrong with them. And we need new approaches to device therapy. Well, I have my own philosophy in device technology and in what we need. And I often have discussions with my boss, and I have a bit of a controversial standpoint. Arthur, my boss, who's going to speak later, he wants us to implant less ICDs, do better risk stratification so we can get less ICDs into patients. But we've just seen that it's a big issue, and what I've heard this morning from everybody talking about risk stratification, that seems quite difficult to do the risk stratification. So why don't solve all of that by making the devices better and try to protect everybody? And perhaps that's now already, in this period of time, a bit too soon, but let's strive to that. ICDs that give no harm, or at least defibrillation therapy quickly to people who need them. Well, we need some things for that. We need less invasive devices. We need less hardware in the heart or in the body. We need to improve longevity of the hardware that you're going to use, and definitely we need better software or algorithms, but we need better IDs. And I have an ID, and I think it's a perfect ID. I'm going to show it to you. So this is my perfect solution. Let me introduce you to Fokko. Fokko is our EP fellow, and we give him an AED, and we ask him just to follow a patient at risk. Here you see the patient, and we just ask him to follow him for 24/7. Well, this is, I think, the perfect solution because it's non-invasive, there's no hardware in the body, there's a good longevity. You probably need 2 of them because he needs some sleep, but a good longevity, and he's 100% effective due to a superior algorithm in his mind, depending on if he's been drinking the night before, but let's say his algorithm is the gold standard. Only one issue. Unfortunately, this is obviously very, very cost ineffective to follow all our patients at risk. So we need better solutions. Well, what I want to show you is a recently started Dutch invention, which is an AED drone. And I can tell you a lot about it, but I'm just going to show you a little movie that explains what it is. Here it goes.
112 operator, what is your emergency?
It's my dad. I think he had a heart attack. Please help. He's not breathing anymore.
Please stay calm. What's your name?
Joanna.
Good, Joanna. We've got your location. The ambulance drone is on its way. Remove his top shirt to uncover his torso.
Okay.
Great. Can you go to the nearest exit? The ambulance drone is almost there.
Okay. I'm outside.
I'll be talking through the drone now, so you can put down the phone. Now please pick up the drone and bring it to your father. Okay, pull the green lid. Now place the pads on your father's chest. Good, I can see that the pads are properly applied. Joanna, please stay clear of your father. We'll take it from here.
Okay, and we'll stop here. And I think this is an excellent idea. Well, it's not ready yet. This is the first prototype, but it is working. And so I think it's a very, very good idea. It's non-invasive. There's no hardware in the body. Perhaps at the current point of time, there's some limited longevity or range. The batteries of drones don't carry that far. And perhaps in windy circumstances, you will have some issues, but it's a good idea. The only downside about it is if there's no bystander, then it's going to be very ineffective. So you still need a bystander. And that's, I think, the unwitnessed arrest is still about 30 to 40%. So for that, we need stuff that actually is with the patient. Another example of that, the wearable cardiac defibrillator. Now we're getting more into stuff that we actually use. So the Life Vest is a wearable AED, and you wear it on your chest, and basically what it does, if the device picks up an arrhythmia, it starts charging. These gel capsules pop their gel out so that there's going to be contact with this metal part with your skin, and you will be shocked. And it is very effective. What it's doing now, indication-wise, we're bridging to recovery patients with a cardiomyopathy, or to the point that they need an ICD, just in the period that you're putting them on medication. Or patients who have an ICD infection, you have to take the ICD out, then you can bridge that recovery period with this Life Vest. So it's a very good alternative to protect your patient non-invasively. There you go, non-invasive, no hardware in, but it's still on the body, and there is the first problem already. That is brings a lot of discomfort. So our patients that wear that, they have a compliance of about 2 months, and then you see the compliance rate going down. You can check them through a server online, and the percentage of time that they wear it goes down. And if they don't wear it, it's not effective anymore, and that goes down as well. Furthermore, there's a limited longevity, I think, due to the cost involved with this device. The cost in our country costs 3,000 euros per month to rent it, so it is quite an expensive way of protecting your patient. So I think that's another permanent solution. So let's look up at a new option that is a permanent solution, and that's this. And I don't know if you've seen this one already, but this is the intravascular ICD, also called the inner pulse. And basically what it is a large sausage with a lead attached to it, and the sausage part contains the batteries and all the technology, and this is just your standard lead. And the idea is that you implant this entire device intravascularly through the subclavian vein, and then shove it through the SVC to the IVC with a lead fixated in the myocardium. Then you could be able to shock between these three coils, and the device obviously is in the patient itself. So they've tested it already in animals, and in animals it's been proven very effective, and here you see the pictures of that in the DFT testing. And even some friends of ours in the Prague hospital have tested this device already in humans. Now, and those were acute studies, so they only received it for this test when they were receiving a traditional transvenous ICD. And here you see the inner pulse implanted with a traditional ICD lead in place. And basically the most important results are over here, where you can see that I think that's 9 and for the traditional transvenous device, and about 7 DFT for the intravascular ICD. My opinion about this, the advantage might be that you have an ICD that the can is not under the skin anymore, but now it's entirely in your vasculature. But this is definitely not a way I think we should go. It's very invasive, I think. It's even more hardware in the body. We never know if you're going to get this out. You still have a lead attached to it where we know what lead issues give. There's no information yet about the longevity and the effectivity, but the system looks like it has a traditional sensing, a way of sensing, so that's going to probably give the same issues as with transvenous devices. So, in my opinion, I think the best device currently available to deliver us less harm in our patients is this device, the subcutaneous ICD. And it's been introduced into the market, in 2008 with the goal of just getting out of the vasculature and solving lead issues. Currently, more than 4,000 of these devices have been implanted worldwide, and over 200 of those in our center. And basically, what is the SICD for the ones that don't know the device yet? It's a less invasive device, so the lead is outside the chest, under the skin, in front of the heart, and the can is in the mid-axillary region, also under the skin. And it's only a shock box. So with smart sensing, it is a morphology-based sensing algorithm. It detects the arrhythmia and it shocks you. So there's no pacing and ATP capabilities from this device. However, there is some post-shock pacing. And when you look at the data currently out there with this device, there are 2 large registries with this device, the Effortless registry and the IDE registry, and they both show a very good induced and spontaneous shock efficacy of the device. So the SICD basically does what you want it to do. If you have an arrhythmia, it will shock you and it will terminate the shock. When you look at things like inappropriate shock rate, it's about 7% in the Effortless registry, which is quite comparable to transvenous devices, but I think we can do even better with some more smart programming. Now, looking at the complication rate, because that's what we are aiming for, Just showing where most of the data from the Effortless comes from. It's from the Netherlands and from the UK, so we can be proud of ourselves that we gathered this data with the help from Pierre. Thank you very much, Pierre, for the help in that. And this is from Pierre's hand. This is the complication-free rate in the Effortless registry, basically showing you that there was a total complication rate of 6.4%, with the majority of complications being infections, lead dislocations, and erosions. And I think, and we're working on a paper that's showing that this can be even lower, that we can see that later in the later implants in Effortless have even lower complications than this. So if you compare that to the 16%, in the SCUTF registry, that looks very promising. And you have to remember the follow-up in the SCUTF was quite long, so the follow-up in Effortless wasn't that long yet. But this 9% is, most of that is lead fractures. And to date, and that is a very strong number, 0.0, there have been 0 lead fractures with the SICD. So the promise of a longer lasting lead seems to hold true. Okay, so which patients have been selected in these registries? That were patients, obviously not that needed pacing, ATP or CRT. They were basically class 1 and 2A indications, primary and secondary prevention. But when you look at the baseline statistics of the Effortless registry, you see that there was a preference for patients where physicians thought there was a perceived benefit. And what kind of patients are there? What patients do we think have a perceived benefit of an SICD? Well, first of all, patients who have limited venous access. Obviously, if you don't have to go to the vein, an SICD might help you. Same issue with congenital patients, sometimes difficult to get into the heart, or a lead in the heart might cause thromboembolic complications. Young individuals, we've just seen that they have the most complications, certainly lead complications. This is one of our players from our team Ajax in Amsterdam that suffered a cardiac arrest and ended up with the SICD and is playing fine in the competition now already for 3 years. Even in pediatric cases, this can help. This girl ended up getting a cardiac transplant where it was very useful that there were no leads in the heart. And I think the best category are patients who have an increased risk for lead infections, and especially hemodialysis patients who are on the machine 3 times a week have a very high risk of getting infectious endocarditis or lead infection. So, who benefits from an SICD? Pacing, ATP, CRT, and I think that's approximately 50% of the patients not. The niche indications that I just showed you, it's about 10%, very likely. But what we don't know is the class 1 and 2A indications for ICD. So basically your MEDIT and SCUTF population, which is about 40%. We don't know. So what we need is randomized trials. So that's why our center started with, to get an answer to this question, we started the Praetorian trial, which is an investigator-initiated randomized trial, multi-center in the EU and US, comparing SICD versus transvenous ICD 1-to-1, with the primary endpoint being ICD harm. And we're going to follow them for 4.5 years. We need 850 patients. Study design is already published. And we're heavily enrolling. And we're not the only ones enrolling, because I want to thank especially the sites in the UK that are helping us with this effort. And I think that this study really is going to give us a very important answer if this device actually is going to give us less harm if we give sudden cardiac death prevention. But no traditional ICD benefits in this device. No pacing, no ATP. Can we solve this? I think we can, and it's already there in the near future. So our hospital is also pioneering with some other new companies that are developing leadless pacemakers. And here you're going to see one of the first patients in the world getting a leadless pacemaker, a nanostim pacemaker, which is an 18 French, 4 centimeter long screw-in pacemaker. And here it's still in the catheter, and I'm injecting some dye to visualize where the apex is. Once it's found, you can screw it in, do some measurements and then finally when you're satisfied you release that pacemaker. Medtronic, a year later, also developed their version of a leadless pacemaker, which is the Micra. It's basically the same concept, it's only a bit shorter and thicker. So it's a 23 French catheter that you need to use to get into the vasculature, and here you see the large catheter going to the heart. And the Micra pacemaker is still protected inside a little cup, and it has little tines sticking out, which are still protected. And if you push the pacemaker out, the tines grab the myocardium and anchor the pacemaker somewhere near the apex. And then you do a tug test to see if the pacemaker is really attached to the myocardium. And obviously after that you do some electrical measurements. And if you're satisfied, then you cut because it's still connected with wires to the catheter, you cut the wires and the pacemaker stays in place. So, and I think that these devices really have the potential of, well, now only RV apex pacing, but perhaps also right atrial pacing, and perhaps in the future even CRT pacing with leadless devices might be envisionable. So, perhaps in the near future you will have your SICD patient and a leadless pacemaker combined. And this is not so far in the near future because we already tested in our animal lab if this is feasible, and we'll show the results later, but basically the answer is yes, those two devices will work perfectly together. Well, I hope that with these images I've given you just a glimpse of what is there in the near future in device therapy, and obviously I don't know where it's going, but I hope that with less harm we can protect more patients. Thank you very much.